So whenever we talk about an anatomic position, this is what we mean. So we mean the patient with their flat feet on the ground, standing straight up, palms forward. Whenever you are asked any question about anatomic position, this is the position that we are trying to focus on. Be aware of that. Alrighty. You may also be asked questions about body planes or anatomical planes of the body. Um, these are basically going to be cross sections of the body to kind of differentiate between one side or the other. So the first range, or the first plane, is going to be the frontal plane. So this is going to differentiate between the back and the front of the body, or anterior and posterior portion of the body. So in this plane, we're going to cut the patient in half, again separating between the front and the back of the body. Our next plane is going to be the sagittal plane. The difference with this is going to be left and right. So whenever we cut the body in half, it's going to divide into the left and right half of the body. The last plane is going to be the transverse plane. So whenever we use this plane, it's going to cut the body into up and down, or superior and inferior. You may get questions asking about different planes. So that's what they are. The frontal, also sometimes called coronal, sagittal, maybe called midline, and then transverse. All right, let's go ahead and let's go to the skeletal system. I already did. Skeletal. Mm-hmm. So if you want to go ahead and zoom in on the skull. So the skull is made up of several different types of bones. Lots and lots of bones. The cranium itself, we have right on the forehead, we have the frontal bone right there. On each side, we have a temporal bone. Yeah, the temporal bone. Also kind of on the side is going to be the parietal bones. You have what's called a parietal ridge in the side of your head, and it's those two junctions. And then on the very back of the cranium, it's the occipital bone. You also have an occipital ridge as well. The face itself is also made up of various different bones. The orbit itself, the eye orbit, we're made up of the frontal bone, and we have the zygomatic bone, which is kind of the like cheekbone, the apples of your cheeks. We have the nasal bone that also makes up the the orbit, as well as the maxilla, or the upper jaw. Speaking of, yep, lacrimal bone right up in there, and then the ethmoid, correct. Sphenoid is another portion of kind of the cranium, just lower down. Yeah. And here we have the sphenoid bone. Sphenoid bone. This protects a lot of the glands in your brain. And then I think if you turn downwards, we can get a view of the foramen magnum. Yeah. So that little opening right there is called the foramen magnum. That is where the end part of your brainstem and the spinal column go out in the foramen magnum right there. If you want to go back to the face, we talked about the upper jaw, but your face also has a lower jaw down there at the bottom. It's called the mandible. And those two meet at the T&J joint, right in there. There you can see the canal for the ear. The ear also has bones. The ear is made up of 3 different bones that basically vibrate and hit each other to make noises to convert the vibrations into sound that your brain can comprehend. Moving on, we have the spinal column. That first vertebrae is very important. That is called the atlas. So that is C1, cervical 1 atlas, and it's basically what the head sits on. We want to be really careful with spinal injuries in C1 and C2, which is also called the axis, because this is where we're having, if you do have some sort of fracture or spinal cord injury in these areas, you're going to have pretty much total deficits. So it may be difficult for breathing. You may need a ventilator to breathe. It may also cut out on some of your cardiac systems. So those two tip-top vertebrae are definitely super important, and we definitely want to minimize any sort of injury in those areas if possible. So your C-spine has 7 vertebrae. Yep. So C7 is that last vertebrae. If you turn to the side view, notice how the spine is very smooth and is in line. There are some curves which are natural, but for the most part, it's very smooth. Whenever we get into the trauma section, you'll hear stuff about like spinal step-offs, where there's an uneven alignment of the spine. It typically indicates some sort of injury. Know that it's not supposed to be there. It's abnormal. The spine is supposed to flow very smoothly. After the cervical column, we're going to have the thoracic spine. The thoracic spine is going to have 12 different vertebrae, and it's going to extend from the bottom of your neck until about mid-back. Attached to these vertebrae are also going to be your ribs. So you have 12 ribs. And then if you want to go ahead and spin on the front, yeah, there we go. Also attached up here at the front is going to be the clavicle bones. It's the one that goes straight across. Whenever we have clavicle injuries, we want to be sure that the ribs right behind it, so the first and second rib, are also not injured just because of the location. Yeah. Attached to the clavicle going down the chest is called the sternum. The top wide portion of the sternum right there is called the manubrium. The bottom tip of the sternum is also called the xiphoid process. Whenever we're doing CPR, we really want to stay on the lower half of the sternum, but we want to stay clear of the xiphoid process just because it's very easy to kind of break off, and we definitely don't want that. It'll cause trauma. As you can see, the ribs do not go all the way around. They do not meet at the sternum. The highlighted portion right there is going to be costal cartilage. So a good half of your ribs is actually cartilage, not so much bone. That's where whenever we're doing CPR and someone says, oh, you're breaking bone, in reality, you're just ripping the cartilage off of the sternum and the ribs. So they're kind of free floating. A lot of times you don't actually injure the ribs unless you're doing CPR incorrectly. You're just, again, ripping that cartilage off. All right. Again, there's tons of cartilage within the body, cartilage on the nose. The majority of the nose is cartilage. Yeah. If we want to go back down to the spine, look at the lower spine. So after the thoracic cavity, or after the thoracic spine, we have the lumbar spine. It's made up of 5 different vertebrae. Now, these are not going to attach to any sort of ribs or anything like that. And again, they're the lower portion of the spine. So it's about mid-back until about hip range. After that, you have what's called the sacrum. The sacrum are going to be 5 bones, but they're all fused together. Here in a second, we will pull up the nerves and we'll put them together. You'll notice that the nerves really kind of flare out right in this section. It's kind of the tail end, so much so that we actually have a name for it called cauda equina, which is basically horse butt or horse tail, because they look so much like a horse's tail. If we go back to the skeleton, they're at the very bottom, past the sacrum, we have what's called the coccyx. It's again a fused bone made up of 4 smaller bones. And then if we want to move towards the hips and get an anterior view, perfect. So this is a male pelvis. The pelvis is made up of actually a few different bones. So that top arch is called the ilium, right up there. You know that the ilium is talking about a bone because it has an eye in it. There is another ilium in the body, but it's said with an E, and that's for the intestines. Then the bottom kind of portion is also called the ischium. And then also the pelvis is made up of, yeah, it's going to be kind of that back kind of butt bone almost. And then the top portion, anterior portion of the pelvis is called the pubis, or the pubis symphysis. And you have left and right of both of those. Also, be aware that there are anatomical differences, especially in the pelvis, between males and females. If you notice, this is a very narrow pubic outlet. It's not very rounded. You can notice that the pelvis is kind of heart-shaped, whereas in a female pelvis, looks very different. There you go. In a female pelvis, the outlet is going to be very much round, and this is going to accommodate for giving birth through the birth canal. Also, if you move a little bit anterior, there we go, you'll notice that the ischium is a different shape. It's more of like a butterfly shape rather than like a heart shape. And then if you move back a little bit, you'll also notice that the ilium crests are further apart, again, to allow for the anatomy to shift whenever you're pregnant and having a baby. We can move back to the male skeleton. Perfect. Moving downward, we have the femurs. The femurs, the very top of the femur, that little neck and ball is called the greater trochanter, and that socket is called the acetabulum. So the greater trochanter fits inside of the acetabulum. Whenever we're talking about hip fractures, stuff like that, we're actually talking about that neck and the greater trochanter. Most of the hip fractures are going to, again, be at that neck of the femur. This is one of the longest and strongest bones in your body. So we definitely have a high index of suspicion if we have one or more femur fractures. It means that there was a lot of force being put on that body. Moving downward, we have the patella. And the patella is a free-floating bone. Fun fact, babies do not have patellas. You develop them as you grow. And so only adults and older children have patellas. Again, moving down, we have the tibia and the fibula. The fibula is that smaller outside bone. The tibia is going to be that larger. If you feel on yourself underneath your knee, there's going to be kind of a flat portion to your like shin. That's going to be your tibia. That is also the site for if you need any sort of intraosseous infusion, so into the bone, you would insert the IO into that tibia tuberosity right there, that flat portion of the tibia. Again, moving downward, we'll move down to the feet and the ankles. So the feet and the ankles are made up of quite a few different bones. We have the calcaneus, which is going to be the heel bone right there. Yep. That's going to make up the heel as well as part of the ankle. We will have the talus bone. Again, that's right up on top of it. That's going to connect to the tibia and the fibula. Then moving downward, we have the tarsals. There are several different tarsal bones. Moving further down, we have the metatarsals, which are the kind of length of the foot. Again, several different metatarsals. And at the end, we have the phalanges or the toes, the digits. If we want to move up to the arm, we can talk about the bones of the arm. So one of the first bones of the arm, we have the scapula. That's going to be that shoulder blade type area. Attached to it is going to be the humerus. Perfect. Moving down, again, humerus is a big long bone. So for breaking the humerus, we need to have a high index of suspicion. Moving down, we have the ulna and the radius. One way that we can tell the difference is if you look at your hand flat, your thumbs, whatever side your thumb is on, that is going to be your radius. Because if you have your thumbs outstretched, the thumb makes an R for radius. Attached to that is going to have the carpal bones. Again, it's, I believe, 8 bones in the carpal region, little tiny bones. And then attached to the metacarpals, which again are going to be the length of your hand, the longer portion of your hand. And then attached to the metacarpals are going to be your phalanges or your fingers, your digits. Awesome, awesome. Here's again just kind of an overview of the skeleton. If we want to go ahead and add in muscles, we can start on those. Perfect. So there are a couple of different types of muscles. The majority of our body is going to have voluntary or skeletal muscles. So this is going to be muscles that you can move on your own. So like for instance, right there on the chest, we have the pec muscles. We also, if we move a little superior, we will have the, yep, those would be like your accessory muscles. Perfect. Right in there. Sternocleidomastoid muscle. If they're breathing really difficult, those muscles in their neck are going to start moving to try and force air in. Awesome. If you look right now, all of your ribs are going to have intercostal muscles. So muscles in between the ribs. Again, these are going to be used in any sort of patient with severe dyspnea or severe shortness of breath. They may use these intercostal muscles to try and force air into their lungs. Yeah. So these are going to be the skeletal muscles. They attach to the skeleton, you're able to move them. Another type of muscle that we have are going to be smooth muscles or involuntary muscles. These are going to be muscles that we use for breathing, use to circulate blood throughout the body. We don't have to think about it moving. One example, it's kind of both, but one kind of example of a voluntary / involuntary would be that diaphragm muscle. So that muscle right there is going to contract and expand and allow your lungs to fill up with air or exhale. So if it's in the upright position, you're exhaling. If it's in the lower position, you're going to be inhaling. And it basically creates a negative pressure within the chest to allow for air to come in. And then the last type of muscle is going to be cardiac muscle. It's not found in anywhere other in your body other than the heart muscle, because it's very special. the cardiac muscle kind of beats on its own. So it's very special. It's not anywhere else in the body. So we're just highlighting a couple of different muscles on the body. We have the biceps here at the front. Yep. Triceps there on the back. The deltoid muscle. Perfect. Perfect. The trap muscle, if your patient is unconscious or we're trying to guess the level of consciousness, you can actually do a trap pinch. It's quite painful, which is why we do it. We check for a pain response in your patients. So you would just pinch the trapezius muscle, and if they stir or if they get agitated because of it, they have a pain response. So they are responsive to painful stimuli. And then if we want to move down, we have the glutes. Yep. Specifically for EMT basics, you may be asked to give an epinephrine injection or some sort of intramuscular injection. We typically want to do this in the outer thigh just because it's a nice big meaty muscle. So it's part of the the quadricep muscles. That's just a muscle system made up of 4 muscles in your upper thigh region. We want to do this just so that the medication can be absorbed as best as possible. Perfect. Do we want to go ahead and pull up the respiratory system? Great. So the respiratory system is going to be made up of a few different things. It is going to be made up of obviously the lungs, but attached to the lungs, we also have the trachea, which is that tube that runs kind of down your neck and up into your throat. The trachea right there. The trachea is going to kind of bifurcate into your main bronchi. And then from there, the bronchi will kind of turn into all of your bronchioles and stuff like that within the actual lung tissue itself. So also on the trachea, we have the thyroid cartilage, which is going to be kind of like that Adam's apple type thing that you can see in males. And then we have the mouth itself. So that upper portion connected to the nose is going to be the nasopharynx. This is going to be, again, the upper portion of your mouth. Then the back portion of your actual mouth is called the oropharynx. Again, just back portion of the mouth, leading into the laryngeal pharynx. Whenever we talk about respiratory, your respiratory is divided into 2 separate respiratory systems. So we have the lower respiratory, so anything past the epiglottis. Yeah, vocal cords, anything. So yeah, there's the uvula, there's the little epiglottis and the epiglottal opening right here. So anything past that, anything past the vocal cords is going to be considered the lower airway. So if your patient has a lower airway infection, it's going to be talking about either the trachea, lungs, bronchi, anything lower than the vocal cords. If they have an upper respiratory area infection or something upper respiratory, it's going to be anything above the vocal cords. So again, that nasopharynx, oropharynx, all of that stuff would be considered upper respiratory. Awesome. If we want to start, yeah, perfect. So this kind of shows you kind of how the air pathways bifurcate and divide. The main trachea is going to bifurcate into the bronchi, the bronchus, the main bronchus, and then within the lungs themselves, we're going to have the bronchioles, and those are going to lead to the alveoli, which are those air pockets that fill with air and allow for the gas exchange into the blood circulation. Be aware that your lungs have 3 lobes on the right, but only 2 lobes on the left. And the reason being is that your heart is pretty midline, but slightly to the left. So in order to make room for the heart, the left lung only has 2 lobes, whereas the right lung has a total of 3. Perfect. And then kind of going back a little bit to the musculoskeletal system, the bronchioles within the lungs are going to be that smooth muscle. So they're going to be autonomic. You don't control them typically yourself. It's something that happens within your brainstem that, you know, causes you to breathe. So that's kind of the smooth muscles is lining your lungs and air pathways. Cool. Do we want to go ahead and look at the veins in the circulatory system? Perfect. So here's looking at the veins in the circulatory system. Something to point out is that there's veins everywhere. We have a couple of different classes of veins and or arteries. So the main arteries, basically the largest artery, is going to be this one right down there, so the aorta. It goes from the top of the heart and goes down towards the abdomen. Yeah, there's perfect. Way down, goes down to the thoracic aorta, and then the abdominal aorta. This is the largest vessel in your body. So if you were to accidentally nick this or sever this artery, you bleed out very, very quickly. The aorta is going to kind of turn into larger arteries, like the femoral arteries down in your legs, or the, femoral arteries down there. Perfect. From there, arteries will turn into arterioles or just smaller version of arteries, down until we have like the capillary bed. So the arterioles will turn into a capillary bed, and it's basically, they just get smaller and smaller and smaller and smaller. Yep. So here's the brachial artery and the radial artery up in the arms. Brachial artery is going to be upper lower portion of the arm, and then radial is going to be down in the bottom of the arms. You also have a couple different, yeah, there we go, radial artery. Perfect. This is where you're going to, the majority of the time you're going to get your pulses from, is this radial artery. Whenever you're getting a heart rate on a patient, you'll get it usually from the radial artery. unless they're unconscious or unless there is no radial artery, beat, in which case you'll go up to the carotid arteries. So these are the arteries that are running parallel to your trachea, and they run on either side of the neck. Yeah, there we go. They run on either side of the neck. Awesome. And so all arteries are going to be taking the blood away from the heart. So for the most part, except for one exception, all of the arteries are going to be taking oxygenated blood away from the heart into the tissues. Veins typically will be bringing deoxygenated blood into the heart so that it can be circulated and reoxygenated and then go out to the rest of the body. So looking at it, some pretty important veins, we have really the largest vein. We have the vena cava. The vena cava has both a superior and an inferior section, and they both go to the right atrium. And they bring deoxygenated blood into the right atrium so that it can be pumped into the lungs, reoxygenated, and then pumped back to the rest of the body. This isn't super important as far as EMT basics is concerned, but whenever you move on forward to AEMTs or paramedic level, you may have to cannulate or get an IV in either of the external jugular veins in the neck right here. So we have external jugular veins as well as internal jugular veins. Sometimes this is called an EJ, and it's basically just where you put an IV catheter in the neck in those external veins. This is going to be for patients where they don't have any other vascular access, and so your only IV would be in the neck. Or if they need quite a lot of fluid or quite a lot of blood very quickly, we would put it closer to the neck just because it's very close to the vasculature. You'll get it circulated very, very quickly. And then probably the most important portion of the circulatory system is going to be the heart. Like I was saying before, the heart itself has a specific type of muscle. So it has cardiac muscle. The reason why it's so fancy and so specific and so important is that the cardiac muscle actually is automatistic. So it has automaticity, which means that it creates its own beat. It doesn't need any input really from the outside to create its own beat. It does that on itself. There's 4 chambers to the heart. So the upper portion of the heart, those are going to be the 2 atria, and we have the left and the right atria. And then the lower portion of the heart is going to be the ventricles, and we'll have the left and the right ventricles as well. This kind of covering over the entire heart is called the pericardium, and it's actually kind of a sac, and there's fluid inside of it called pericardial fluid. And so sometimes, depending on the patient's illness or injury, you may get an excessive amount of pericardial fluid in there, and it may squeeze the heart. Awesome. Yeah. Perfect. Yeah. So if we look at it, we can go in and see There's the left ventricle. That is going to be the pretty much largest chamber of the heart. And the reason why that is so big and the muscle on that is so large is because we need that extra muscle to pump all of the blood to the rest of our body. So that muscle has to get blood all the way down to our toes, which is why it's so large. If you ever look at a combined portion of the heart, and we'll probably see that here in just a second, compared to all of the other portions of the heart, that left ventricle is very, very large. Within the heart again has 4 chambers. So the upper chambers are going to be the atria, and kind of the junction point between the atria and the ventricles are going to be the valves. I don't know. Yeah. Yep. Yeah. So you have valves in between the atria and the ventricles. You also have valves in between the pulmonary veins and the pulmonary arteries, and then the aorta. And it's basically those are created, or those were, the function of those are to keep the blood inside of the chamber of the heart so that there's no backflow. And so once the blood goes through one valve, it kind of seals off so that they can't go back the way that they came. Awesome. Do we want to go ahead and put the nervous system up there as well? So obviously our entire body is innervated. So we have nerves from the top of our head to the very bottom of our feet. The nerves basically are going to send electrical impulses to and from the brain to do various different things. We can have sensory nerves that are going to send signals to the brain, so that the brain can kind of decode different senses like touch, taste, smell, all of that stuff. We also have nerves that perform functions within the body. So if you go into the thoracic cavity, you'll notice these little nodes right here. They're within the heart. And so those nodes actually create the pace or the heart rate of the heart. They're called pacemaker nodes. So the SA node, that's going to be in the ventricle. It's going to send an impulse down. Yep, that's what I meant. That's what I meant. The atrium. It's going to send an impulse down to the AV node, or the atrioventricular node, which is in the ventricle. And then from then, there it goes into the different bundle branches and Purkinje fibers and all of that stuff. Yeah. But yeah, basically, the entire body just has nerves running up and down it. And again, if you want to flip around to the posterior section. Yeah. So down here at the bottom, again, that's what we were talking about, the cauda equina. And again, it's just because it looks like a horse tail, and it connects to the spinal cord. And from the spinal cord, it will innervate all of the like leg function and stuff like that. The spinal cord is going to run up pretty much the entirety of the back and connect to the brainstem, connected to the brain. If at any point this pathway has been severed or damaged, the patient may lose any and all function. So that's why it's super important that we preserve spinal function, and we want to be careful about any sort of spinal precautions. Yeah. Yep. So there's the inlet, or I should say outlet. There's the start of the spinal cord, and usually the spinal cord stops around L1, L2. And again, it shows you how that spinal cord goes all the way through the foramen magnum and connects to the brainstem and the rest of the brain. Cool. Do you want to go ahead and pull up? Perfect. So this is going to be the lymphatic system. And within your body, you have lymphatic pathways that will help with lymphatic drainage, movement of lymph from one part of the body to another. There are a couple of different organs involved in the lymphatic system. So up there, kind of in the upper chest, you have the thymus, and then you also have the spleen. So those are going to be the two major organs whenever we're talking about the lymphatic system. And if you kind of notice, if he goes in kind of close, you'll notice like those little nodes, those are lymphatic nodes. So if you have any sort of illness, they may swell with lymph to help protect your body. This is part of your body's immune system and how we try to fight off infection as best as possible. So yeah, if your doctor or you here in a little bit, if y'all ever palpate your lymph nodes and they're swollen, that's what you're palpating, those little nodes in the lymphatic pathways. Perfect. Do we want to go to the integumentary system real fast? So the integumentary, or your skin, is one of the largest organs in your body. It is the largest organ of your body. The skin's built to protect you, built to kind of regulate your temperature, make sure that, you're sweating appropriately or shivering appropriately. There are typically 3 different types, or layers, should I say, of the skin. So this top layer is called the epidermis, and it's very thin, usually only about 7 cells thick, very, very thin. The middle portion is the dermis, that is the thicker layer. That's where a lot of the structures within the skin is housed. And then the bottom layer is sometimes called the hypodermis, or the subcutaneous level. This is going to be where the fat and like the sweat glands are kind of housed. So if you look right there, that little scrunched up curly Q thing, that is a sweat gland. So our skin uses those to help regulate our temperature. We also have a hair follicle, and then we have erector pili muscles right in there. Yep. These erector pili muscles are going to, again, help with temperature regulation. That's what causes the goosebumps whenever you get a chill or anything like that. Those erector pili muscles. That's what it's causing. We also have those little yellow portions. That's going to be your nerves running in. Obviously, there are nerves throughout the skin helping with sensory, as well as temperature regulation and stuff like that. Also, you can see where the vasculature is and where it runs within the skin. Perfect. Let's go ahead and go to the digestive system. So the digestive system has kind of a lot of muscle or a lot of organs. The digestion itself actually starts at the mouth. We have those saliva glands on either side of our head to kind of secrete saliva and start that digestive process. Once we swallow, once the food goes in, it goes through the esophagus, all the way down to the stomach, where stomach acid will continue the breakdown of food. Typically, the liver is going to produce a majority of the bile or the stomach acid to help break down foods. But if you have an overproduction of bile, you may also have bile stored in the gallbladder. We also have the pancreas, which is responsible for the most part for your blood sugar or blood glucose swings. It works in conjunction with your digestive tract to make sure that your blood has just the right amount of blood glucose. If there's too much, then it releases insulin, and insulin goes in, unlocks the cells, and pushes glucose into the cell. From the stomach, we will enter the small intestine. There's 3 different sections of the small intestine. We have the duodenum, and then the middle section is going to be the jejunum. That's going to kind of be that middle part. Usually the duodenum and the jejunum are the ones that do the most digestion. So a lot of times nothing is even absorbed until it hits the small intestine. So the duodenum and the jejunum are usually the ones that absorb any sort of nutrients that our body needs. And then the ileum is that last portion of the small intestines, and that typically will get the very last, the bare minimum that is left of the nutrients before it goes into the colon or the large intestine. So that first portion is called the cecum. That's just the kind of transition from the ileum to the large intestine. The appendix down there at the bottom can get very angry and cause some issues, cause appendicitis. If it gets too inflamed or has too much infection, it can actually rupture. And then the rest of your large intestines over here, your large intestine will kind of compact all of the fecal matter and make it to where it can be expelled. Also, most of the water is kind of absorbed in the large intestine. And then the large intestine is connected to the rectum and the anus so that you can eliminate all of this. All right. So there are a couple of different organs involved with the urinary system. One of the main ones are going to be the kidneys. So basically what this does is it filters the blood, filters out any toxins or anything that shouldn't be in there in the blood, and sends it to the bladder to be expelled as urine. So connected to the kidneys, we have ureters, and it's that tube-like structure that connects the kidneys to the urinary bladder. Once in the urinary bladder, then it can go down the urethra and be expelled as urine. In male patients, we have the prostate gland. This can actually cause some difficulties for your patient, usually later on in life. It can cause the patient to not be able to relieve themselves and not be able to urinate. So sometimes if they're having urinary dysfunction, it's because of the prostate gland. In men, you have a longer urethra, so you usually are not as prone to urinary tract infections, just because it can be flushed out, and there's a longer distance between the tip of the urethra to the bladder. Whereas for female patients, that distance is much smaller, which is why female patients are more prone to urinary infections and UTIs. Also, a lot of times UTIs are kind of asymptomatic in females. So sometimes females don't notice that they have anything going on. And that's why females are more likely to have kidney infections than males. This would be a perfect segue into the genital and reproductive system. So for females, we have a uterus up here. It's about the size of the patient's fist, and it's covered by the pubic symphysis. Attached to the uterus, we have the fallopian tubes. The fallopian tubes are what is going to allow the egg to travel from the ovaries to the uterus. So fun little component of that is the ovary is going to house the egg, mature the egg, and then whenever it's ready for ovulation, the fimbriae, or the little finger-like projections here at the tip of the fallopian tube, it's not actually connected to anything, but the fimbriae will kind of collect and kind of sweep up the egg from the ovary and allow it to pass through the fallopian tube into the uterus. So we have that umbilical ligament. Do we want to go ahead and switch to the male reproductive system? For the male reproductive system, obviously, there's a little bit of a different anatomy. We have the scrotum, which is going to house the testes. This is where sperm is created and stored. From there, we also have the penis, which is going to house both the urethra and There we go. The sperm will also use their urethra as a way to move out of the body. And that pretty much wraps up human anatomy.